A little bit about me. I'm an academic GP and a professor of general practice at Newcastle University. And as a GP, I have an interest, a huge interest in promoting mental health and supporting patients who do have mental illness to self-manage and become healthier. My research is into health inequalities, and in particular health literacy. So what I'm going to talk about today is what health literacy is and what mental health literacy is. I'm going to describe some models of health literacy, talk about why health literacy is important and why mental health is important, and how building skills can promote mental health. And then there's going to be, I'll summarise what I've talked about, and then we'll have plenty of time for discussion. There's a lot of references here because this is quite a scientific presentation, and there is a full bibliography that's available as a PDF for anyone who wants it. So you could email Yaya after this presentation, and she will make that available to you. So health literacy, quite a complex definition here, but at its core, it's all about the capacities of individuals, families, and communities to get hold of, understand, and use information in order to make decisions about their health. So it's a very broad concept. Part of it, of course, sits within the medical consultation, which is how, of course, I got into it and how we all know. And what's important about this is that it emphasizes the importance of physical, mental, and social well-being. And it is something that is positive. So it's not merely the absence of disease or infirmity. It's actually a positive state to be healthy. And then if you pull that together into mental health literacy, this is not the international definition, but I think it's the best definition, so it's the one I'm going to put here, which is essentially taking that nice broad definition of health literacy and just focusing it on mental health. So here's a model from that Ruth Parker pulled together, which I think is really neat because it shows that health literacy is a balance between the capacities of individuals, families, and communities, and the demands and complexities of the system, so that one can see that the more difficult and complex the system, the more skills and capacities people need in order to be able to operate within that. And the reverse is also true. If one makes the system simpler, people can more easily manage their way around it. Part of that is, of course, the health system, but there are other systems that are really important here. And in particular, for things like mental health, that's the social care system, the benefit system, there's the employment environment, how you manage your way around that. So it's all those different systems within which people live and operate that are required for health literacy. So just to put this into a more schematic format. So I think the situation we have in the UK at the moment is that we have very complex systems. I know the health system best, and it is extremely complex. I have to support people in working their way through the social care system, and that is equally complex. So what really excites me about lifelong learning is that what it does is it builds capacities within individuals, within families, within communities. And that then, of course, increases health literacy so that people have the skills they need to get what they need from the system. So this model I put in just to kind of show the breadth and complexity of the concept of health literacy and how it can be applied for managing disease if one has, say, depression or schizophrenia, how one has the skills to be able to manage that. There's disease prevention, so how do you support someone who's previously had depression, maybe, and support them to prevent them getting it again. And then there's health promotion. So mental health promotion would be promoting mental health across communities so that it's seen as a positive thing to have, and the systems are in place to enable people to achieve mental health. It's worth looking a bit more deeply into health literacy definitions, and the reason I've done that in this presentation is that this helps us to think about the different ways in which we can build skills, and what we have here is increasing levels of complexity and cognitive difficulty. So at one end, we have the functional skills. So that's the skills to be able to read and write and understand numbers, to be able to function effectively in everyday health and social situations. Then there's communicative, interactive skills. So this is more advanced literacy and numeracy skills. It also starts to bring in language skills. So do people have the language and the confidence to use their language in order to be able to communicate and discuss their health? And then there are the more critical health literacy skills. So these are the skills that enable people to look at information, analyze its importance and relevance for them in their everyday lives, and use that information to take control over their life and their health. So why is health literacy important? And that's going to be what I'm going to talk about now. So firstly, it's important because of the number of people who are disadvantaged through low health literacy. So this is the result of a study that I led that was published a couple of years ago now. And what it did was we looked at health materials in common circulation, and we looked to see how difficult they were to understand. And what we found, and we then compared that difficulty with the results of the 2011 Skills for Life National Literacy and Numeracy Survey. And what we found that was on average, 6 out of 10 people did not have the literacy and numeracy skills they needed to fully understand and use health information in common circulation. So that's a huge proportion of the population. You'll also see that there's regional variation, and that maps onto the sorts of patterns that are so often seen with situations that have a social gradient. So there's the relatively affluent south, there's the relatively more deprived northern areas where people are facing more difficulties, and then one has London as a region of deprivation in the south. So that's the first thing to say. The second thing to say is that actually, even having said that, this is a significant problem right across the country. Even for those areas where there are the least problems, you still have more than half the population without the full health literacy skills that they need. So that's the first thing. It's very prevalent. It's a big problem. It affects lots of people. The second thing is that health literacy is actually associated with health. So the higher people's health literacy scores, and this slide here is from the European Health Literacy Survey, which took place in 8 countries back in 2011 now, and it shows that the higher people's health literacy scores, the healthier they feel. And we know from epidemiological work that certainly at population levels, how people feel translates very closely into actual mortality. So not only does higher health literacy promote better health, lower health literacy actually puts people at higher risk of illness. So people are more likely to have a long-term health condition, and if they have a long-term health condition, they're more likely to find it limiting. They find it more difficult to take their medication as instructed. They're less likely to engage with disease prevention like cancer screening. And for older people, they die earlier. So not only do people feel less well, they're also sicker. So this is another slide looking at social gradients and looking particularly now at individual characteristics rather than regional variation. And so we find that gender does seem to be important. Men have more problems with literacy skills, women with numeracy skills. Older people have more problems, people from minority ethnic groups, born outside the UK, with a first language other than English, who have low qualifications at school leaving age, who are unemployed or in a low job grade, have a low income, are not owner-occupiers, or live in a deprived area. So what this shows is that these are people who are already facing lots of barriers to health, and low health literacy is just another one. And if you look at all those characteristics together, most of them stay in the model. Although interestingly, and this isn't the case internationally, for instance, if you look at the States, it's different. But certainly within the UK, whether or not you're born in the UK is actually not important. That's explained by whether or not English is your first language, or whether you're a member of a minority ethnic group. And unemployment, again, is totally explained by your job grade and your income. So we've shown that there are costs at an individual level, but there are also costs at a system level. These data come from the States, so they need interpreting with caution because the American health system is very different from the UK, of course. But it does appear that between 3 to 5% of the total healthcare spending is actually eaten up by extra services needed by people with lower health literacy. And if that's the case in the UK, we're looking at between 4.5 and 7.5 billion pounds a year. So it not only costs individuals and families a lot, it costs the system a lot too. Okay, so moving on to mental health. As with health literacy, this is something that's extremely common. 1 in 4 of us are going to face a mental health problem each year. And in fact, 1 in 6 of us face a mental health problem in any given week. So it's hugely prevalent. It's also very, very expensive. And it's estimated to cost 4.5% of the gross domestic product. And that's a combination of health costs, productivity costs, and benefit costs. So if you look firstly just at the healthcare costs, this is the breakdown. If one's interested, it's interesting to me as a GP that actually less than 10% of the healthcare costs are incurred in general practice, whereas in fact most of the care for people with mental health difficulties occurs in general practice, but actually most of the cost comes from elsewhere in the system. So if we can care for more people in general practice and support people better in general practice, that's going to help the healthcare costs. But then if you look at the wider costs, those costs I was showing on the last slide are actually only 15% of the whole healthcare costs. It's those wider costs to society, the loss of productivity, people on long-term sick leave, people on benefits, that cost the vast bulk of the money. As with health literacy, social gradients are present in mental mental health. We know that particularly for anxiety and depression, that's much commoner in women, but you can see that also it's much commoner in people from the lower, more deprived social groups, so far more likely to be facing mental health issues. This is a bit of a busy slide, but what I like about it is that it captures the complexity of the system and what causes social gradients in mental health, and the fact that it's a lifelong thing. But also it helps to think how lifelong learning can actually help at various stages in people's lives. And I would see building mental health literacy skills as being a lifelong activity that should start right in early years, go right through the school, involve people as they're at work and learning to cope with work. And then as people get on to into the older ages, learning in older age groups is also fantastically helpful in promoting people's mental health. So this is really a lifelong issue, and education and skills building has so much to add. So I said right at the beginning that one of the reasons I'm so interested in health literacy is that actually it's a social determinant of health that we can do something about. So difficult to pull people out of poverty, for instance, to raise people's incomes, to get them living in healthier environments, but actually one can build health literacy skills. And this shows that building skills actually promotes people's mental health. So that's also hugely exciting. And it's very interesting. In the next few slides, we're just going to look at how that might happen. Some of it is in terms of promoting healthier lifestyles. On to the next slide. A lot of it is around people keeping their mind and their body active. And actually, people with long-standing health conditions, almost all of them said that that was the case. It was slightly lower for people without long-standing health conditions, but even so, 9 out of 10 said that it helped them to keep their mind and their body active. It looks as if participation in learning prolongs active life, delays dependency, and sustains independent living. So particularly important as we start to get to those older age groups. And there's something about being involved in a learning group that actually seems to promote mental health. So I'm going to present a few findings from a report that Jan Nowitzki wrote, which talks about the outcomes from some community learning innovation fund projects that were funded by the Skills Funding Agency. 96 projects were run between September 2012 and July 2013. And these are the outcomes that they looked for, given the previous research findings, and what they found was this was also true in terms of the outcomes from these projects. Improved well-being, reduced anxiety and stress, better physical activity, better mental health, less reliance on external agencies, and less depression. So very, very exciting and real findings. So just some thoughts about why this happens, because it's a bit of a black box at the moment. You take people who might perhaps have problems or potential problems with their mental health, you engage them in lifelong learning and they get better, or lots of them get better. And as a scientist, it's very interesting to think about why that might be. So here are some thoughts from me. Firstly, there is something in here about building mental health literacy skills, particularly for people who've had mental health difficulties in the past. It's around improving literacy, that you can talk to your doctor and nurse about it, and you can talk to your friends, you can talk to your family. One of the issues, I think, is that medics go into medical school as normal people, and they come out of medical school as doctors who speak a different language. And we have to unlearn that language as we learn to talk with our patients. But actually, giving people the language to be able to understand and confidently speak the terms that are needed to understand mental health is really important. There's something here about healthier lifestyle choices. If people live more healthily, if they smoke less, if they drink less, if they get more exercise, they actually feel better. About neurobiology that's sort of underlying this. Now, this is obviously not my area, but I do think there is something probably about altering people's stress levels and how that feeds into how their brains work and their neurotransmitters. I think there is something around that too. So pulling this all together, health literacy and mental health literacy is important for individuals, communities and society. It's important because people with lower health literacy feel less well, are more likely to get ill, cost the system a lot of money, and there's a social gradient to this which is inherently unfair. Similarly, mental health is hugely important because it's common, it costs a lot, and there's a social gradient. You see, there's a lot of overlap in these two areas. There's good evidence that adult learning promotes mental health because it supports building skills and confidence, including mental health literacy. It supports people to live healthier lifestyles. It builds a sort of social network infrastructure and the support that comes with it, and it may well influence neurobiological pathways. And the only other plea of mine is that the most resource should go to those people who have the most need. We know that education and lifelong learning is expensive. We also know it's effective, and we should target our resources wisely so that it goes to the people who need it most.
Great. So the first question is from Monica Liang, who's joined us from Canada this morning, which is great. We'd love
Hi, Monica. Hello.
And so Monica says, I'm a literacy teacher and working in the early stages of a project that connects literacy teachers with a health clinic for refugee patients who have low literacy and little or no schooling in their language. Mm-hmm. Does anyone know of people and projects that I could connect with, read up on, that works with low literate adults and mental health with refugees?
It's not an area that I couldn't put you in touch with people, but I would have thought, Yaya, that that's something that your group would know a lot about. So do we know of courses like that are going on within the UK?
I am aware that, whilst others please do join in, I am aware that there are some findings around new arrivals in the UK from Syria through the government resettlement programme and low literacy skills amongst some of the people who are arriving through this scheme, and also some efforts being made there to develop and make available ESOL provision that will look at improving the literacy as well as language.
There's stuff in here also, isn't there, around culture as well as skills. And I'd be really interested in hearing from those of us in the group who are teachers, who are educators, around what it's like, what are the difficulties and challenges of actually bringing in issues of culture into lifelong learning, because part of the reason people are more at risk of mental health issues must be the cultural shock of being in a place that is so different, and not only are the systems different and the language is different, but the culture is very different. So I'd be really interested to hear from colleagues who have experience and skills in that area.
Hello, my name is Alessia Kogo. Some cultural issues that I had when I was teaching English to groups of refugees and asylum seekers were mainly related to their understanding of my role as a teacher and their role as students. So their understanding of, for instance, of how you would behave in the classroom and what you would do, and how you learn in the classroom. And a lot of them had this idea that teachers are the source of knowledge, and so they would expect me to provide them with all the answers and solutions, and they wouldn't interact very much with their colleagues or look for information around them. And so this idea of where is the authority and who is the authority is something that created some misunderstanding in the classroom.
That's very interesting, Alessia. Sometimes people coming from other cultures come from a culture where they go to the doctor being expected to be told what's wrong with them and what they need to do about it. So again, it's a sort of cultural passivity, and actually it takes a lot of work to address that and actually get people to welcome and use that sort of more equal, less hierarchical, more active approach to health. But it can be quite a difficult thing to do, because actually I've had experience where I've said, well, you know, what do you think we should do about this? There are all these different options, and actually people have gone away and said, well, she doesn't know what she's doing. She doesn't know, you know, what the right answer is. And so I think there are a lot of similarities in terms of those cultural approaches. People move towards that more active, participatory approach, I think. So a lot of the, presumably there's almost a sort of learn how to learn process in the lifelong learning world that needs to happen before people are in a position to actually get the most from their learning.
Yes.
And there are also issues, there are also cultural issues around mental health. I mean, mental health has a lot of stigma anyway, but actually within some cultures the stigma is far, far worse, and actually that's really difficult for people. And so people not only need language and literacy and numeracy skills, they also need support and confidence. So again, I guess that's something that the lifelong learning environment is a very secure and good one for building up those sorts of skills and confidence, isn't it?
May I add something there as well? I think from a classroom perspective, there's lots of risks involved in bringing these questions up. I think teachers feel unprepared to deal with the content of mental health discussions, to deal with the privacy risks associated with it. And I think there's a lot there that teachers want to bring up, but are unsure of how to do it professionally, how to do it accurately. They don't want to give the wrong information. And then they're quite, I think, often unprepared to deal with what comes up. How do we deal with this in a classroom? And there are also risks, I think, too, for disclosure. I mean, I think there's a lot of people living on the edge in our classrooms anyways, where they're worried that if they disclose something about their mental health, that might have some sort of repercussions on them. whether or not they're allowed to stay in the class or receive the services or whatever it is.
Yeah.
So I think those are some of those risks.
Yeah, and that may be a very sensible concern, actually, you know. And one of the approaches that I think could work really well here is to have a sort of more cooperation, I think, between the health and education, particularly, I think, in the area of mental health, because what I want as a GP is for my patients to have the skills to self-manage, to know how they can reduce their risk of getting less sick and how they can increase their chances of staying healthy, but also that they know when things are going off kilter and they need to come back to me. And building those skills is not something that I'm equipped to do because I'm not a teacher. On the other hand, what I can do is I could bring to a lifelong learning class some of that medical expertise. So actually a situation where doctors and nurses and other health professionals supporting people with mental health issues can have the option to refer people to good lifelong learning courses, but also that the people running lifelong learning courses can actually invite doctors and nurses to come into some of the sessions. You know, that might actually add quite a lot in terms of some of the issues that you've been raising, I think. So I'd really like to see more of a mix. At the moment, it feels like it's really separate. Certainly in the UK, you have the health system, you have the education system, and you don't have very much mixing. But I think there's so much to be gained from having more of a mix. I don't know what others think about that.
Hi, it's Sue from Bury. We took part in the community learning mental health research, and we also had a social prescribing project in one of our EP practices, where a number of organisations from working in all different areas would go sit in the GP practice. I was there on a Thursday afternoon, and it was great, but that was really, it was just one or two GPs really. So a really great idea. I had learners come directly from that. They took part in the project, and it worked for them. It worked really well for them. We fed back to the doctor. The individual doctor was so enthused by it. But it's just rolling that out really. We know that GP's time is limited and, you know, very busy, but it's just about making those links and us all finding time somewhere as well, really.
Yeah,
but a really great idea.
Yeah, and I think the way to sell it to GPs is that actually, if it works, it should actually reduce the GP's workload, because this is all about giving people extra skills and capacities to self-manage and to understand things better. And actually, what it should mean then is that people are less likely, if you look at somebody, say, who comes through this route, you're likely to get someone, say, who's had multiple episodes of depression and anxiety. That's the sort of person that you might get. And actually, if this works, that person then should be less likely to need to come back to the practice. And if they do come back, it's because they really recognise that things are going wrong for them and they need some extra medical help. So it should be really effective in terms of time, because what I as a doctor have to do is say, look, I know you're finding this really difficult. This is and you know, we've got all the medical stuff we can offer that we would still offer, like the cognitive behavioural therapy, medication if needed, etc., etc. And this is another option which might help you to sort of get more skills and confidence. And to me, that's all I'd need to do. And then to know I had somewhere good to send them. That surely could only be a good use of my time. If I go and talk to a group of 15 people with a history of mental health problems in a lifelong learning setting about how to promote their mental health and how to know when the danger signs, when things are going bad and when they need to go to their doctor. That's got to be a fantastic use of my time. So I think a lot of it is about how it's presented. And one of the things that I'm doing is working with some people who've done these community learning pilots who want to explore developing these links and getting referral pathways and fundings from the health service through to education. And we'll have to see how it goes, but I'm very hopeful that with an open-minded health funding area in the UK, that would be a clinical commissioning group, or in England it would be, that actually in a Scottish Health Board, if you have an open-minded health funder, I would have thought they would see lots of advantages to that.
Going through my head is the fact that we're sitting here talking to you online, and one time saving would be to invite the doctor to come in for, you know, a 10-minute slot within a class, but to do it in an online environment like this. And those projects did have access to, you know, tablets and digital devices, and were encouraged in group meetings and things to use Zoom. So there are ways round, aren't there?
Yeah, I think so. Yeah. And every area is going to have their own mental health leads. So actually, it's the sort of thing that they should be really open to. And a proportion of them will even be prepared to do it by Zoom. I suspect most of them will go, but you will get a proportion of them prepared to do it by Zoom. And those that aren't happy to do that, then they can always, if they're prepared to travel, come and talk in person, can't they? But there's been, for instance, the online CBT courses that we now offer to patients been fantastic in terms of their cost effectiveness, their scalability. They've been well used, and once patients have the confidence and skills to use them, they've been absolutely fantastic, and they cost a fraction of the cost of running a face-to-face CBT course. So I'd have thought it's the direction to move in, certainly. Thank you for the opportunity to come and talk to you all. It's been really exciting, and I love the chat. That's terrific. And yeah, so best of luck to anybody who wants to take this forward. And my email address is on the presentation, so people can always continue to talk to me by email if that would be helpful.